Okay, no Powerball though. Okay, so I gave this talk last year. It was the 2024. This is the 2025. Wound care is an interesting thing because, as I mentioned previously, it's the one field where you have about 15 different faculties of medicine that are all doing it, right? Primary care, vascular, plastics, infectious disease doctors, primary care physicians, physical therapists in places, naturopaths, Google, right? Everybody has their opinion on wound care. And it's because of that, there's a lot of inconsistency, right? And so if you do this all the time and it's basically the backbone of your practice, you get a little bit of a different flavor than for when you do it on the weekends, right? So and a lot of the esteemed faculty of here have kind of come up and talked about certain things that they've had in their practice, and there's so much to that. Learning from people who really see this and are in the muck and the mire. It's very different than just opening a kind of a book. With that in play, I'm going to talk about some of the new burgeoning technologies, right? So I'm sure that at least once or twice a week, someone comes over to your offices and tries to sell you something, right? And this is the newest, greatest thing. It's going to heal everybody, right? So what I had to do was try to piece through what's out there that's on the horizon. Some of the stuff is a little bit in the future. Some of the stuff is here right now, and maybe can generate a little bit of interest in the group to give you some excitement. And then I'll talk a little bit about my research in my next talk. Okay. So here are the things that I kind of broke down. There's new technologies in monitoring and diagnostics, such as smart bandages, non-invasive imaging, wearables. In the treatment and regeneration component, we have a lot of bioengineered tissues, 3D bioprinting, which we'll talk about, some nanomaterials, and some stem cell therapy, which I'll talk about a little bit later. And then there's some advanced therapies through e-stim and ultrasound with AI, of course. Everything's peppered with AI, right? So let's talk a little bit about smart bandages. This is something that is out there, but not really, I would call it, in the vernacular right now. I think if you're a researcher, you may be starting to get some of this out there and using it, but it will be there very, very soon, okay? So what's a smart bandage, or why use a smart bandage, right? So smart bandages, they're basically have flexible electronics and also traditional dressings, right? And they help facilitate healing. So you have, and we'll go through these, right? So you have a bandage with some kind of sensor or way to communicate through near communication with the smartphone through an app, right? And here, when the sensors are embedded in this dressing, you can basically do a lot of things, right? You can see what the pH of a wound is, right? Most of the time, a wound is slightly acidic. So if you have, you're measuring the pH in real time and you see it go down and becomes a little more basic, then you say, oh, there's some inflammation in there. Let's go ahead and change what's going on. Temperature, right? Elevated temperature of a wound can indicate infection. Moisture levels, we're always battling with moisture levels, right? If something's too wet, something's too dry, imagine being able to sense it and then say, okay, now I know how to make those changes. I don't have to wait for the maceration to kind of slough off the tissue. Oxygen levels and other biomarkers. So you know that there are certain things in the wound, lactate, uric acid, peroxide. These are all things that happen throughout the wound to indicate infection. And if there are indicators that you can sense with these smart bandages, you'll know about it a little bit earlier, right? This then gets transmitted to an app. And the same way now that you can see there are some wearables, right? Maybe some people in this room are using it, where you can check your EKG on your iPhone right now, right? There are these, it's like $99, right? You kind of grab your iPhone with your two fingers. It gives you a real EKG, read, and then it can go to your cardiologist if they have a problem, right? We have wearable halters right now that go to the cardiologist to be able to see those types of things, right? CPAP machines do that. Whenever they do sleep studies, that you have these types of things as well. So there are these remote ways that your patients can tell you things without actually seeing you, which is really good. I mean, you'll say, hey, I'll see you in 2 weeks, but what if that indicator lights up 2 days later? You can say, hey, come in tomorrow. You had a warning sign that came in. Okay? There are also ones which have active treatment in them as well. E-stim has shown to stimulate tissue growth and increase blood flow and also reduce bacterial loads. You can also give drugs through there as well, like antibiotics or anti-inflammatories in a targeted way. And then, of course, machine learning. The more we know, the smarter the AI gets, the more we can kind of get this biofeedback with the patient. In the future, so what are we looking for? We're looking for earlier intervention, right? We notice the problem before the patient kind of comes into us. Better outcomes, and then reduce cost, right? So if you could, I mean, in my office, I see patients with wounds once or twice a week, right? If they have an active thing. But imagine I only had to see them 2 or 3 times a week. That would save a lot of money for the healthcare system and also probably free up a lot of my own personal time. All right, so that's smart bandages. Fluorescence imaging. So this is real. It's real, but it's still very, very expensive, right? So here's a handheld device that shines a light. It's like kind of a black light that shines onto the wound, and certain things fluoresce differently. So red will fluoresce Staph aureus, blue is going to fluoresce Pseudomonas, and green fluoresces collagen. I've used this before for some of my clinical trials, which is really how I know more about it. But the cost of that item right there is about $20,000, and you can't really recoup any money on it yet. There are codes for it, but so far it's very difficult to get paid on these types of things. But why use fluorescence imaging? Well, you can tell what's good or bad, right? If you have to debride something, you know it's targeted. If you see that there's a trouble area that fluoresces, you can do a biopsy of that area. You can also start treatment earlier, right? You thought the wound was healing fine, and then you put the light on and it goes, oh, it's completely colonized. There's biofilm everywhere. You can then get some faster healing rates. And then also, again, if you're seeing wounds all the time, antibiotic stewardship, right? So, you know, how many times do we have somebody comes in with their first ulcer and go, hey, you know what, here, let's just put you on an antibiotic, right? The wound may not be infected, we're just doing that. But now you can say the wound's not infected because I know it's not infected. When I fluoresced it, nothing actually came out of it, so I don't need to give you an oral antibiotic. Here are a couple of cases. These are not my cases, but here's a wound that looks pretty clean. When you shine the material on it, you can actually start to kind of see that there's still some bioburden that's left around over here. There's all staph, and this is after you debrided it. Now, if you looked at this, I mean, this looks like a good wound. I'd be like, great job. Let's wrap it up and go home. So after it was debrided again, then they looked at it in 2 weeks, and now you could see that whole Staph aureus rim around that wound is gone. Same thing here with the sacral D-cube. Here you can kind of see how it's shining, red here, and then after you clean it, you can kind of see that place has gone down. Here is interesting. They thought this wound was okay. They then decided to culture the wound, and then they decided to use a different antibiotic. And then after they used a different antibiotic, it came back better. So I think that's a real interesting thing for people who work in large wound care centers, or you work in an academic center where the cost of that type of unit may not be that cumbersome, but in private practice or in other venues, it may still be something which is difficult to acquire. 3D bioprinting has been around for a bit. It kind of took a little bit of a I would call like a back seat. It's back a little bit more right now. But the idea here is to use your own skin, put it into, bring it into a lab, take a piece of your skin, bring it to a lab, make a lot of it, and then give it back to the patient, right? So you put it into a bioreactor, you take a little, you make a lot, and then you're able to help with healing. Okay, so there is a commercially based product that's on this. Am I allowed to mention a commercially based product if there's only one? Is that okay? Or probably not, but let's just call here autologous heterogeneous skin construct. You can look it up. This is the generic term for it, but basically you would harvest a full thickness piece of skin, you send it into a lab, then they cultivate this tissue for you, and then you have a lot from a little, and then can apply this bioactive material, which is your own tissue, to the wound. So this is like a piece of full thickness, which is, I was in on this clinical trial, but it was very, very difficult for me to do this because I had to harvest full thickness skin, and that would be from the thigh. So I was calling my vascular buddies to be able to go ahead and do this, and they just couldn't get on board at the same time as I was. So it was something I had to abandon. But basically here you would take out a full thickness piece of tissue and then send it back. You then come back a second time to the operating room to do the application, and you apply it to the prepared wound. Here are some cases that Armstrong and his group did for this. Again, debride it, you take a piece of tissue from a different site, send it to the lab, come back, and this is how it goes. Okay? So this is something that's out on the market. And again, employed. If you work in a group that has teams that can harvest full thickness grafts, because these are not split thickness tissue grafts, they're full thickness grafts. It's something that you can do, especially for larger area wounds. It's a little harder in the foot, especially from a diabetic perspective, because the patient has to be stable, in order to be able to send it out and go back to the operating room twice. But at some point in time, this large event that happens with 2 trips to the operating room is probably they're going to thin this thing out, and they'll be able to kind of get there soon enough where you yourself will be able to take the biopsies and do the same thing, because they won't need as much tissue. Okay, so that's what's new out there for now, and then I'll come back again afterwards and we'll talk about some platelet grafts for wounds as well.